Assalamu alaikum, the clinical day. We have Miss Jennifer. She's 18 years, presented with repeated syncopal attack. Her blood pressure 140/90. The rest of the vitals are normal.
Hi, my name is Dr. Ahmed. I'm one of the doctors in the clinic today. May I confirm that you're Mrs. Jennifer, 80 years old?
Yes.
Nice to meet you, Mrs. Jennifer. We're here today to discuss some issues related to your health condition. I might need to take some notes, but everything will remain confidential, and I'm giving you all my attention. Is that okay with you?
Okay.
So it came to my knowledge that you are coming with repeated syncopal attacks or fainting. Can you please tell me more about that?
Yes, doctor. From the last 2 weeks, I have repeated 3 times. I have syncopal attacks.
Okay, and can you please tell me what are you doing? What were you doing during the attack or before you get the attack?
Mostly when I'm having attacks, I'm walking. Most of the time, I'm going uphill when I'm having these attacks.
And do you feel dizzy before the attack?
Yes.
Okay, can you please describe the dizziness for me? Is it like spinning sensation or you feel that you're about to fall?
It is just like lightheadedness.
Okay. Do you get any weird sensation before you faint? Like
No.
any weird smell or zigzag lines in your vision?
No.
No. Any numbness or weakness?
No.
Okay. And when you lose consciousness, anyone noticed you losing consciousness?
Yes. Yes.
Did they tell you for
My-
how long have
my
you
wife-
lost consciousness? Huh?
Excuse me. Again.
Did anyone tell you for how long did the loss of consciousness attack last?
It usually takes 4 to 5 minutes.
4 to 5 minutes. And after that, when you regain your consciousness level, do you go back to normal or you're sleepy?
Usually it takes up 1 hour, and up till 1 hour, I remain confused after the attack.
Okay. And during the attack, do you get any? Do you lose control of your body?
Yes.
Okay. And do you get any abnormal movements?
Yes.
Is it shaking of the whole body?
Yes.
Okay. Anyone told you that you got uprolling of your eyes or frothing from your mouth?
No.
Okay. And have you noticed anything during these attacks? Anything else that you would like to share?
Most of the people, my husband is always with me, and he told that during these attacks, you looks to be very blue.
Okay. Anyone checked your sugar during this attack?
No.
Okay. And is it the first time to have these attacks for the past 2 weeks, or you had them before?
Yeah. Yes. First time.
Okay. Do you get any chest pain before the attacks? Or
Yes.
heart racing? You get chest pain?
Yes, I am having chest pain.
Okay. Can you tell me where is the pain exactly?
Pain in the center of my chest.
Can you describe it for me?
I'm having this pain from the last 1 year. This blackout from the 2 weeks. I'm having chest pain from the last 1 year.
Okay. Can you describe how does it feel like? Is it heaviness in the chest?
It's like just like heaviness.
Okay. And have you noticed anything makes your pain worse?
No, when I'm walking, it becomes worse.
Okay. Anything makes it better?
Just if I take rest or sit down, it becomes better.
Okay. Over the past year, is your pain getting worse in general?
In general, only when I'm walking and I'm
Hmm.
going upstairs or going uphill the mountains.
Okay. And on a scale from 1 to 10, how would you rank this pain?
It is 4 to 5.
Okay. Any pain at the moment?
Yes, at this moment, no pain.
Okay. Any shortness of breath during the attack?
Yes, I'm having shortness of breath.
And this shortness of breath, is it more when you lie down or at a specific position or no?
Yes, it is more when I lie flat and more on exertion. Now I'm
Hmm.
also having this shortness of breath even at rest.
At rest. I am sorry for that. We will try our best to help you. And
Thank you.
and how many pillows are you using at night?
Sometimes one, not more than one.
Okay. Any leg swelling?
No,
Okay. Any fevers?
no,
Any sweating, night sweat?
no,
Any weight changes?
no,
Okay. Any like problems with your vision, blurry vision, or any gritty sensation, dryness?
no,
Okay. Any weakness or numbness in your legs or arms?
no,
Okay. Any difficulty swallowing?
no,
Any skin rash?
no,
Any lumps or bumps?
no,
Okay. Any neck swelling?
no,
Any tummy pain or tummy distension, tummy bloating?
no,
Okay. Any change in your bowel habits?
no.
Any change in your water work?
I don't have any problem with my water work.
Okay. Any past medical history I should be aware of?
I'm having diabetes and hypertension from the
Uh,
last 15 years.
Okay. Are you taking medications for this?
Yes, for hypertension, I'm taking Ramipril, and then for diabetes, I'm taking metformin.
Are you compliant to the medications?
Yes,
Okay. Any past surgical history or procedures I should be aware of?
no, no.
No. Any family history of a similar condition or any other health problems?
My father, he has stroke, and my mother, she has epilepsy.
Hmm. Okay. I would like to. Can you please show me? Do you take any other medications apart from the Ramipril and the metformin, or over-the-counter medications or herbals?
No,
Okay. Can I ask you some private questions?
yes,
Uh, do you smoke?
yes.
How many packs?
15 cigarettes per day for last 20 years.
Okay. I advise you to stop smoking because it's like dangerous to your health and it will worsen your condition. If you want, we can help you with that and refer you to our team here.
Okay, ready to quit.
Okay. Do you take alcohol?
Yeah, occasional in the safe limit.
Okay. In the safe limits. Okay. And are you driving?
No,
Okay. Any recent travel or sick contact?
no,
Okay. Can I examine you?
yes,
So I'll start with you told me the vital signs are normal apart from the blood pressure. And I start with the general appearance of the patient, sick looking, any like cyanosis.
general look is normal, but I'm sometimes at this time there's no discomfort at rest,
Hmm.
and there is nothing abnormal, no deformity.
Okay. So I'd like to check the peripheral examination, the hands, for any clumping, any signs of infective endocarditis, splinter hemorrhage, Janeway lesion, Osler's node. peripheral cyanosis, star stain, any?
No.
Okay, I'd like to check the pulse. How is the pulse?
Pulse is 70.
Okay, is it
Regular.
regular? And low volume or high volume or normal?
It's a low value.
Okay. And any collapsing pulse?
No.
Okay, any raised JVP?
No.
Okay, I'll check the eyes for conjunctival pallor and scleral icterus.
No pallor. No jaundice.
Okay, any central cyanosis?
No.
Then I'll examine the chest for the point of maximal impulse. Is it heaving or thrust, like the character of the apex beat?
It is heaving.
Okay, and any parasternal heave or palpable P2 or palpable thrills?
No.
Okay, and I'll examine the heart sounds and for any murmurs.
Yes. At the aortic area, I'm having ejection systolic murmur.
Is it radiating to carotids?
Yes.
Okay. Any bibasal crepitations?
No.
Okay. I'll examine the tummy, abdomen quickly for any tenderness or organomegaly.
No.
Okay. I'll examine the lower limbs for edema, lower limb edema.
No, nothing.
Okay, Mrs. Jennifer, can you please tell me what are your concerns?
Doctor, do I have epilepsy? Like my mother, she was having epilepsy.
I appreciate your concerns, Mrs. Jennifer. Based on the history or the discussion we had today and based on the examination, I think you're having a problem with one of your the valves in your heart. And we need to run some blood tests and do some imaging to confirm our diagnosis and to manage you further. For the time being, we will need to admit you because of these recurrent syncopal attacks and to run our investigations. Is that okay with you?
Okay, again, I'm confused. Do I have epilepsy or not?
I don't think it's less likely epilepsy. It's
Okay.
more likely of a problem with one of the channels in your heart that gets that is smaller in size, so it will reduce the blood supply to your brain. That's why you are getting these syncopal attacks.
Okay, why I'm having these attacks? As you told me that there's a decreased narrowing of one of the valve of my heart. Why my valve of heart has narrowing?
This can happen with age, Mrs. Jennifer. It's one of the most common causes, especially in patients with comorbidities like the high blood pressure and the high sugar that you're having for a long time. And when it is smaller in size, it will reduce the blood supply, and so you will get these attacks.
2 minutes left.
Do you have any more concerns for me, Mrs. Jennifer?
It is curable?
Yes, it has a treatment. We can refer you to the heart doctor, and it's usually, they will assess you if you need any surgical interventions. Most likely. Do you have any more concerns for me?
Okay, right now you will admit me?
Yes, we need to admit you because you are having syncopal attacks. That is serious.
Okay.
How does that sound for you?
Thank you very much. Thank you very much, doctor.
Thank you, Mrs. Jennifer.
Okay, if you're done, you want to ask any more questions?
No, mashallah, she did.
Anything in the
I
examination?
forgot the CNS examination.
Still, you
also.
have 1 minute, so you can do whatever you want. Still, you have 1 minute. Go ahead, please.
Okay, quickly, I will do then tone and power quickly, tone, power, and reflexes, and I'll check the gait.
It will totally normal.
Okay. I don't know. Should I do cranial nerves?
There's no need for the cranial.
Okay.
Pronator drift, did you do?
No, I did not do. Okay, I will do pronator drift and I will check the gait.
Okay, consider time is up. Let's go to the examiner questions. You can start, Dr. Azhar.
Okay, please present your case.
I have examined Mrs. Jennifer, 80 years old female, who's complaining of repeated syncopal attacks. In the history, she's been having positive findings is syncopal attacks and dizziness, especially with exertion associated with chest pain and shortness of breath. She has a past medical history of diabetes and hypertension for 15 years, and a family history of epilepsy and a stroke. She's a smoker, and on examination, she has a low volume pulse and a heaving apex beat with an injection systolic murmur at the aortic area radiating to the carotids. No signs of infective endocarditis and no signs of volume overload. The summary to my findings are features suggestive of aortic stenosis.
Do you have any differentials?
Differentials, aortic sclerosis, but against that is the radiation to the carotids. In aortic sclerosis, there will be no radiation. Another differential for ejection systolic murmur is HOCM, but as well, HOCM, the location will be different in the third intercostal space on the left side, and there will be no radiation to the carotids.
Any more
And
differentials?
usually it is in younger patients. Sorry?
Any more differentials? Can you consider pulmonary stenosis?
Pulmonary stenosis. It can cause ejection systolic murmur, but as well it will not cause, the location will be different, and it will not cause radiation to the carotids.
Any more?
I can't think of any.
Low blood sugar may be possibility.
Yeah, you are right. Maybe.
Drugs,
Drugs?
because the patient is taking ramipril and metformin. Ramipril may be
So,
sometime. So how you will investigate this case?
apart from the basic investigations, we will do ECG and echo to confirm the diagnosis and to check for other valvular abnormalities. The patient might need coronary angio to check for other like what is it?
Any other coronary artery disease?
Yes.
Okay.
And
How you will manage it?
management, non-pharmacological and pharmacological, disease education and counseling, refer the patient, multidisciplinary team approach, refer the patient to cardiology. Most likely the patient will need valvular replacement, aortic valve replacement in view of the recurrent syncopal attacks.
Okay. Will you go for the surgery or percutaneous?
Because of the old age, yes, I think percutaneous. I'm not sure, honestly.
Okay. If the patient can tolerate surgery, we will go for surgery. If cannot tolerate, we will go for percutaneous. Okay. Which valve you will play?
The aortic valve.
Tissue valve or mechanical valve?
Tissue valve, because the patient is old age, 80 years old.
Okay, very good. Tissue valve, because there is no need for daily monitoring with the blood with anticoagulants.
Yes.
Okay, thank you very much. Mashallah, you did
Thank
very
you.
well. Welcome. You did
Thank
very
you.
well. You almost cover everything. I don't have any comments. Dr. Basam, he can comment.
Yeah,
Thank
but
you.
Thank you.
still there is 40 seconds, so I can give here more questions.
Yes,
Give
yes,
me,
yes.
please.
Okay, you finished the echo as tool for diagnosis, right?
Mm-hmm.
Anything else you want to do in the investigation, I mean?
And then apart from echo and cardiac catheterization,
Yes. Any lab workup you want to do?
yeah, cardiac enzymes, troponin, BMP.
Yes, always remember the specific test for cardiac case. You have to do this test. Troponin and
Okay.
yes, BMB for heart failure signs. And would you suspect infective endocarditis in this patient?
No, there are no signs.
Yes, because if no signs, we will not think about. But if you have any valvular lesion, you have to think about it, and you might put it in the complication, right?
Yes,
Okay,
true.
the driving. You ask him about driving. What do you think about driving?
He should not drive because he's getting the syncopal attack. So if he said that he's driving, I would counsel him not to drive.
Yeah,
But I
so
didn't. He
yeah,
said
till,
no.
till to confirm the diagnosis. But if confirmed, this is aortic stenosis. Will you allow him to drive?
Until after no, until after
Until
replacement.
management. Yes, exactly. Because he has this attacks even while he's sitting. Okay, thank you. I'm done. Thank you, Dr. Ryan. Dr. Azhar, you can start commenting now.
No, mashallah, she covered each and everything. I don't have any comment. I don't have. Mashallah, she covered each and everything.
Okay, good.
Thank you.
Well done, Dr. Ryan.
Thank
Just
you.
I want to ask you for the comment on the palpitation. You didn't ask about the palpitation, and it's one of the cardiac signs, right?
You're right, صح.
Yes. So you can ask either you have any awareness of your heartbeat, and while doing examination, you can comment as you did. You comment on the pulse, the volume, and the regularity. Patient might have also AFib. And general advice to you, whenever you have 80s as patient age, better to start with the past medical history, right? You might have the clue in the past medical history, diabetic autonomic neuropathy, for example, or you might have a hypertensive patient taking diuretics. It will be the clue. Epileptic patient, stroke patient, it will be the clue from the start. Diabetes as well for hypoglycemia. So in order to be target in the differential and the history taking, you can start by asking the past medical history. After that, the common cause as you did, the diabetes, the epilepsy, and the medication or dehydration. Plus the cardiac, if you have chest pain during the attacks or before. But anyway, you can do it as you did before and during and after. And when you regain your awareness, was it fast or takes time as you did? But in general, whenever you have patient elderly, please ask for the past medical history. One important also history here, the surgical history, as you ask for the procedure, the patient might have pacemaker, and it will be the clue in this patient or any scenario else. So he might have either malfunction pacemaker, and you will get the clue from also the history, which is surgical history. Okay. Drug abuse, if you suspect infective endocarditis in young patient, and he has other risk habits like the recreational drugs or sharing needles, you can ask, but you will suspect it in younger patient. And while doing examination, as you did, in infective endocarditis signs and symptoms like injection mark, the splinter hemorrhage, and the signs of infective endocarditis. So it's important as well to roll it out. Apart from this, really, you did perfect. And you remember at the end also the neurological examination, just roll out stroke or TIA. And 2 or 3 tests maximum you can do for the CNS, like doing the pronator depth, tone and power, just roll out any lateralization, and cranial nerve examination. One cranial nerve is enough, like facial or any lateralization in the face. One last comment, the blood pressure sitting and standing, you didn't offer it, which
You're
is
right.
very important in this.
Important.
Yes.
صح.
Okay. I guess no more comment. Thank you. And nice case by Dr. Azhar as usual. And well
Thank you
performance
for the
as first
comments.
time. Yeah, first time practice. You did very well. Thank you,
Thank you
Dr.
so
Ryan.
much.
We can
My
receive the
pleasure.
other. Thank you too. We can receive the other comments and question. Please write your scenario for Dr. Azhar. He
Okay.
will prepare himself until I will finish the comments. Okay, we have arrhythmia, yes, differential ischemic heart disease, very well, as she had a risk factor, of course. Tissue valve, yes. Yeah, don't forget TAVI, Dr. Ryan. TAVI, one of the solution nowadays for the elderly and unsuitable surgical patient. They can do the implantation through trans-arterial catheter. Okay.
Okay.
So remember always the TAVI in an elderly patient and patient who's contraindicated for surgery, because not every patient fit for the surgery, particularly the elderly patients.
Okay.
Yeah, how come as differential in young patient always it's a differential to the aortic stenosis and aortic sclerosis, but it will be in younger patient, not in 80s. However, you can consider it in the 40s as well. Okay, with of course with family history of sudden cardiac death. This is one of the clues for syncope with HOCM. Okay. And the other comment, yes, nice, well done. Differential ischemic heart, CVA, carotid sinus syndrome, arrhythmia, ask about driving. Yeah, as she did while driving, if you don't know the reason, you have to stop him driving until you confirm. If you confirm this patient is having vasovagal attack, he can drive safely. So who are banned from driving? The ones with no diagnosis. Once they are diagnosed and they have the risk for having this syncopal attack during driving, during sitting, they will be also informed to DVLA. Okay. Addison, yes, and anemia also very important differential. You have to do it either by question, anyone told you you are paler, or you can examine the pallor in the hand and in the face as well. And anemia is valid differential for any syncopal attack. Addison, agree. If you have, yes, some hypotension, hypoglycemia, you can suspect it, especially in the young age. And you can add it if the patient has a history of TB, for example, or meningococcal septicemia, you can suspect Addison or adrenal insufficiency. Okay. Nice. Any recent dose change? Of course, you have to ask this question. Addison can cause syncope, but patient old for HOCM. Yes, of course. Agree. In treatment, we should stop ACE inhibitor. Yeah. Any medication while patient having syncope, you have to tell him you hold your medication until we confirm the diagnosis, not only ACE. Any medication you suspect it might affect him, especially the diuretics. Yeah, you forget anemia, yes. Okay. Dr. Azhar, you have Mr. Ali, 30 years, coming with complaint of weakness. I'll give you 2 minutes.
Okay.
Then you can start. What's the case about? The new or the old? Okay, the old one was syncopal attacks, and the new one, lower limb weakness.
Okay, can we start?
Sure. I reset the timer. You can start now. Here you go.
Hello, I am Dr. Azhar, one of the junior doctor. Are you Mr. Ali, 30 years old?
Yes, doctor.
Okay, today I'm here to discuss some issue regarding your health, and I will also examine you. and I will, during my conversation, I will also write some notes. Rest assured, all these will remain confidential. Is it okay with you?
Yes, doctor, thank you.
Mr. Ali, I came to know that you have low limb weakness. Can you tell me more about this?
Yes, doctor, since yesterday I'm having this weakness. I don't know what's the issue. It's not getting better.
Since yesterday. Okay. Before
Yes.
this, you was completely normal?
Yes, last week I was normal.
Okay. It came on suddenly?
Yes, it was sudden.
Or it is increasing or decreasing since yesterday, or are the same?
It's almost the same, but it's not improving at all. I cannot walk now. I had to use the cane to come to the hospital.
Okay. It is in both legs or one leg?
Both legs.
Okay. Did you sustain any trauma?
No trauma.
Okay. Did you took heavy exercise yesterday?
No.
Did you took heavy carbohydrate like pasta?
Actually, I was sitting in the dinner with my friends yesterday, so I ate a lot.
You ate a lot. This is the first time you ate?
No, I eat normally. You mean
And
the first
yesterday,
time to have this?
and you took in a very heavy amount.
Yesterday, yes.
And after then, after eating, you slept.
Yes, then I got this weakness from yesterday night.
Okay. Is there, and have you noticed, is there anything which increases this?
No,
Is there anything which decreases this?
no.
Okay. Mr. Ali, I want to know, do you have any past medical history which I should be aware of that?
No,
Okay. Are you using any drugs?
no drugs, no.
Okay. Any family history which should I know?
No, negative.
Your any no any your family member have same problem or some other specific problem which you want to tell me?
I don't know about them, doctor. I am not living with them anymore.
Okay. And have somebody commented you that that are you becoming paler day by day?
Paler? No,
Okay. Do you have any headache?
no,
Any visual problem?
no,
Any problem with speech?
no,
Any problem with your hearing?
no,
Any problem with your upper limbs? Weakness?
no,
Any numbness in the upper limbs?
no.
You have in your regarding your lower limbs, you have only weakness or you have any numbness or tingling sensation also?
Only weakness.
Only weakness. Do you have any problem with your bowel habits?
No. What do you
Any
mean, doctor? Sorry.
uh, problem with your bowel habits? Are do you have loose stool or hard stool?
Yes, I am having loose stool for a while, like maybe 1 to 2 months.
Okay, 1 to 2 months you have loose stool. Okay,
Yes.
these stools are greasy,
No, just
pale,
just semi-solid.
offensive, difficult to flush away.
Never, no.
Okay, have you taken any treatment for these?
No, I did not. I am coming the first time to you, doctor.
Okay. So before 1 month, you are having this loose motion. Before this, you were completely all right.
Yes, I think so. I did not get bothered by this loose motion before, but now they are becoming more frequent.
And how many times you are going to the washroom daily?
Maybe 3 times?
Maybe three. Yeah. It is totally loose or semi-solid?
Semi-solid.
Semi-solids. How you are compensating? Are you taking more
I
fluid?
I eat a lot, doctor, and I drink a lot.
Drink a lot.
My appetite is very good.
Okay. Do you have fever?
No.
Any weight changes?
I think my clothes are looser than before. I did not weigh myself, but my clothes are becoming looser.
Your- Okay. As you told that your appetite is very good.
Yes.
Okay. Since how long have you noticed about changes in your weight?
Maybe for the past 2 months as well.
Past 2 months. Okay. Any night sweating?
No.
Any lumps and bumps?
I feel in my neck there is some small swelling.
For how long?
The past 2 months.
In the past 2 months. Okay. Any history of travel?
No travel.
Okay. Any history of shortness of breath?
No.
Any cough?
No.
Any racing and pacing of the heart?
Yes. My heart is beating too fast.
Okay. For how long?
For the same duration, 2 months.
2 months. Do you feel dizzy?
No, I don't.
Okay. When you stand up suddenly from your sitting position, do you have any dizziness?
No.
Do you have any joint problem?
Joint? No.
Okay. Do you have any blood transfusion?
No.
Are you sharing needles?
No, I'm not.
Do you have tattoos or piercing?
No.
Do you have a regular partner? Sorry to ask you.
No.
Do you have any casual partner?
No, I don't have.
You don't. Do you smoke?
No, I don't.
Do you drink alcohol?
No. No.
Okay. What is your job?
I am an accountant.
You are accountant. Definitely, it is affecting your job. These low
Yes.
emotion. Do you have any weather preference?
I feel hot most of the time.
You feel hot most of the time. Okay. For how long?
2 months.
2 months you are having. Okay. You have tummy pain,
No.
any early fullness.
No.
Okay. Any family member having the same problem?
I am not living with them, doctor. I don't know.
Okay. Any shakiness of the hand?
Yes, doctor. You are right. For the same time that I'm having the heart racing, I feel anxious. I feel shaking.
Any sweating of your hands?
Yes.
Okay. Okay, Mr. Ali, can I examine you?
Yes, sure, doctor.
From the general look, I want to see is there any abnormality on the general look or anything surrounding the patient?
Yes.
Walking aids?
Sorry?
Any walking aids?
Walking aids. He has a cane at bedside.
Okay. Okay, I will start from the hands. Any
Okay.
shakiness of the hand, tremors,
Yes, mild
sweating,
tremor. Yes, sweating is positive.
any clubbing?
No clubbing.
No clubbing. Okay. Any cyanosis of the hands?
No.
No. A pulse?
Pulse 110.
110.
Regular.
And what regular equal? And what
Mm.
about the BP?
Blood pressure normal.
Any postural drop?
No drop.
Any proximal myopathy?
No proximal myopathy, that just the lower limb weakness.
Okay. Then I want to I any pallor or jaundice.
No pillar or jaundice, but I sent you a picture in the chat.
Chat.
Yes.
Share to the group as well.
Okay. Any lid lag, lid retraction?
No. Only this picture, only this view.
Exophthalmos.
No.
Okay. And I also want to examine the thyroid. I will on the exam inspection. I want to see is there any swelling in front of the neck.
Yes, there is a swelling in the neck.
Okay. I will offer you a sip of water. Uh, does it move with swallowing?
Yes, it does.
Okay. Can you stick out your tongue? I just want to see whether the swelling moves or not.
It doesn't move with the tongue protrusion.
Okay, then I will go back and behind. I will palpate the gland, the thyroid gland. I want to palpate. I want to see whether it is smooth or nodular,
Diffuse enlargement.
diffuse enlargement. And then I want to see. I will do percussion whether it is retrosternal or not.
Negative.
Then I will check the bruit.
Negative.
Lymph nodes, I want to check the lymph nodes as you told me that you have lumps and bumps.
No lumps or bumps, only this swelling in the neck.
Okay, then I will go check the heart. Any murmur?
No.
Any heart is totally normal.
Normal,
S1
yes.
normal.
Normal.
Then I will check the legs, tone, power, reflexes.
Tone is normal. Power is 3 plus. Reflexes are hyper.
Hyper. Any sensation?
No sensory problem.
Any coordination problem?
Could not be assessed because of the weakness.
Okay, Mr. Ali, what is your concern?
Doctor, why I'm having this weakness? I am worried why it's not improving.
Okay, after taking your history and examination, I think that you have a underlying condition is thyroid problem, which we call in our language is thyrotoxicosis. And due to this, you are having problem weakness of your limbs.
Is this a serious
2
problem,
minutes
doctor?
left.
Uh, I don't think so. It is serious. If we will treat it, you will be normal. And what I will do at this time, I will make multidisciplinary teams and I will do some blood tests and some scans, an image of your gland, thyroid gland, and when I will be having these results, I will be discussing with you.
Okay, doctor. Thank you.
Do you have any other concern?
No, doctor. Thank you. Okay.
Still 1 minute, Dr. Azar. You want to examine something else?
Examine all the everything and
You examine the tone and power, right? And reflexes.
sensation, coordinate, and gait of the he is walking with the cane.
Whatever, you have to at least
Okay.
offer, right?
Okay, I want to see his gait.
Normal. Could not be assessed because he's, and he just mentioned.
Very difficult because he is working with the cane.
The sensation, did you check the sensation?
Yeah, yes, I asked. She told sensation normal, coordination cannot be performed.
Okay,
because
so
of,
you perform the whole
He performed.
sensation modality. Okay, if you did,
Yes.
okay. Okay, so you can finish and start the examiner question. Let's start.
So can you present your case, please?
Mr. Ali, 30 years old. He has a weakness of the limbs since one day, and yesterday he took heavy amount of pasta, and after then he's having weakness of legs. he is also having weight loss, loose motions, and shakiness of the hand, tremors, and racing of the heart. And then on examination, I found him that he is having exophthalmos, and I did, and the thyroid gland is diffusely enlarged, and there's no retrosternal extension, no brie. And on the examination, tone is normal, power is reduced, reflexes are higher, hyperactive, and sensations are normal, and coordination could not be performed. On the basis of this, that this patient is having uh, periodic paralysis secondary to the thyrotoxicosis.
Okay. Any other differentials?
My differential is periodic paralysis, hypokalemic and hyperkalemic periodic paralysis.
Okay.
But in case of hypokalemic periodic paralysis, although the patient is having history of high pasta, but there will be, we cannot find any history of thyrotoxicosis, and same is with the hyperkalemic periodic paralysis. And if we
Okay.
will go, since the history is very acute, I may put the common peroneal nerve injury, common peroneal nerve palsy, but it is usually unilateral, common peroneal. So, and in common peroneal, there are different neurological examination. There will be weakness of dorsiflexion and eversion, but I could not find in the favor of common peroneal palsy anything.
Okay. What are your investigations?
Besides the basic investigation, CBC, ESSC, recti proteins, LFT, RFT, no, all will be normal. I will do the thyroid functions test. I will do the Doppler ultrasound, and I will do the thyroid receptor antibodies, TSH receptor antibodies, and then I will also do the thyroid scan. And thyroid scan, it will be the uptake will be uniform, and the uptake will be very high. And for the neurological problems of this patient, I will do the nerve conduction study and EMG.
Okay. And how are you going to treat?
The treatment is of the in the investigation. I will also do the electrolytes, very important, especially potassium. I will do to roll out the other differentials. Treatment will be I will make the multidisciplinary teams physiotherapists, occupational therapists, neurologists, specialist nurse, and then endocrinologists. And what I will do, basically non-pharmacological education and counseling about the disease, and about this pharmacological. I will start him anti-thyroid drug carbimazole, and to control his palpitation, I will give him the beta blockers. At the end, I will give him some brochures and leaflets, and I will offer him some contact number. If he has any problem, they can come to my office anytime.
Okay. Any preventive measures?
Any preventive, it's better that you have taken so much pasta, so please avoid pasta in future. It's a triggering factor.
Okay. Thank you, Dr. Asad. Well done. Excellent.
Okay, still
Mashallah.
30, yeah, well done. Still 20 seconds. I will ask him more questions.
Okay.
Yes.
Yeah, you told me about the scan, and you said the scan will be what?
This scan, it will be uniformly uptaken, and there will be high uptake.
Yeah, high uptake in the form of what? How it will not only uniform. So
I think
uniform
you
in isolated area or
diffuse, you meant?
No.
Yes,
It will be
diffuse.
diffused.
Yes, exactly.
Diffused,
So,
because
yeah,
it's not nodular. It's not. If the nodular,
exactly.
then it will be localized.
Yeah, yeah. This is the difference between toxic nodule and the gravis. So you have to be more specified. Yes, it is like diffuse uptake, right?
Yes, yes.
Yeah. Okay. You mentioned the medical therapy. You have any other option for management?
Management, if the patient does not improve with the medicine, then we can give the radioiodine, or we can go for the surgery.
Excellent. Give me indication for the surgical intervention.
Surgery, if the patient is not not improving with the medication and the radioiodine, then we can go for the surgery.
Only this? You have another indication?
I do not know.
If you have dyspnea, source, hoarseness of the voice.
You are right. Yeah. If a dyspnea, shortness of breath, three features: a shortness of breath, difficulty in swallowing, and change in the voice.
Excellent. So this is what's called?
This is triple, I forget.
Compression science.
Huh?
Compression science. Compression science. Yeah, right?
Yeah, just there is some other name also. These I forgotten. These are three
Any
things.
invasion or compression to the surrounding, either nerves or the larynx, what's called esophagus, or even retrosternal extension, compression on the mediastinum. All this, any compression signs, even compression over the nerve, vocal cord, it will be harmed by the hoarseness of the voice. So any compression signs by the goiter, this is indication for surgery. Okay, let's go to the radioactive iodine. What is the contraindication?
Absolute
what are?
contraindication is contraindication is pregnancy.
Excellent.
And the female, I think she should not be pregnant for 6 months, I think. And eye problem, and the eye problem, we will also not give the radio ID.
And one more. Children.
Yes. The patient who is taking radiation, she should remain away from the children around about I forget that 6 weeks, like this. I forget the duration. 6 weeks, I think, or 3 weeks.
I can't remember also the duration, but he or she should be away from children, right?
Yeah.
Okay, if you have eye complication, what's the best and the most important advice?
Patient should avoid this radio iodine.
Okay, yeah. What else?
Patient should use the artificial tears.
Exactly, yes. Use lubricant, avoid dry eye. One more. Yeah, one more advice if the patient is smoker.
Avoid smoking.
Yes, avoid smoking. This is the most important advice. And if the patient is having exophthalmos, you said about lubricant. What other medication you can give and suggest?
Corticosteroid.
Excellent. Okay, that's enough. Full mark.
Thank you very much.
Really, really amazing, Doctor.
MashaAllah.
Mashallah. Yeah, yes. I like.
I forgot in the examination 2 things: acrophagy and mixed edema. No,
Yeah, in the legs. Yes.
Well done.
Yeah. Okay. Let's hear Doctor.
Dr. Rian, if I'm Dr. Basal,
Yes,
you
sure,
correct
sure.
me. I think pasta is related with heavy amount of pasta is related with hypokalemic periodic paralysis.
But it's not
And
only pasta. Any high
It's
carbohydrate.
it's related to both actually, Dr. Azhar.
Mhm.
Both of them, the
you
same
correct me.
triggers, and both of them they will have low potassium levels, by the way. So potassium replacement is one of the management plans in
Yes, yes.
even thyrotoxic periodic paralysis. Okay.
But
Okay.
not only pasta, right? It's any high carbohydrate.
Any
like-
carbohydrate, yes, you are right. Any
Yeah.
carbohydrate load.
Yeah, you specify the pasta in the history, but you can
I did
make
not
it.
actually say pasta.
Yeah.
He said it, and I told him I just ate with my friends.
Yeah, he
Yeah,
assumed it and he
he assumed.
continue
No,
assuming.
Yes.
no. For the weakness of the legs, I have made one mnemonic phase. I
Mm.
have made one mnemonic. If any patient will come with the weakness in legs, so I'm always asking these things: heavy exercise, pasta,
Mashallah.
and, and thyroid problem, because
Mm.
it will rule out everything. And
Give
the
us this
examiner,
mnemonic.
I will tell you at this time. I'm forgetting. I will tell you, inshallah. If I will remember,
Okay.
I will tell
Okay.
you. And the examiner may ask you, okay, you will check the potassium. Potassium is low. How you will replace the potassium?
Mhm.
We will
Mm.
give potassium
Yes.
IV. We will give IV 10 milli equivalent per hour. 10
Mm.
milli equivalent per hour at the rate of 10 milli equivalent. This is
This is in
the
the
examiner
peripheral.
may ask this.
Yeah, in the peripheral line. And
Peripheral line. The
if you
peripheral
have
line.
central line, you can give up to 20, yes.
Yes.
Mm.
And over 24 hours, you can give 1 millimole per kg.
Okay. When I forget this mnemonic because I have made this
No,
forget.
but you did great,
What is
really.
come in mind? Huh?
You did great, Dr. Azhar. You did everything in the case.
Thank you very
Yes,
much.
mashallah.
Okay, let's hear Dr. Ryan comment. Then I will give some comments. Okay, just for teaching, but you have no comment really. But for
Yeah.
teaching
No,
purpose, I
no,
will.
no, no. He corrected me. Both of you corrected me. I was
No.
thinking pasta is only related with hypokalemic paradox. So both
we
of
are,
you corrected me.
yeah, we are learning, Dr. Azhar. No one is perfect. We are here to learn from each other. So let's also repeat the clues from Dr. Ryan. Then I will comment.
Okay, so you did a great job, Dr. Azhar. Thank you so much.
Thank you.
I just have few comments. In the history, when you asked about the weakness, you did not ask about red flags like urine retention and inability to control. You asked about loose motion, but you did not ask about the control. Am I right?
Yes, yes, yes.
Yes. Yeah.
Yes, it's very important. But you ask about trauma, but it's very important to ask about the control as well. You did not ask about previous similar attack.
No, I asked, do you have any attacks
You,
before you?
I
asked.
don't think you ask about similar attack. But if
No,
you
no.
ask, that's
He
fine.
he asked, but you said to him what? You said I didn't have it before the last
No,
week. You said like that. So he considered it
he
the
assumed
first
it.
time. Yes.
Yeah, he told me before you were okay. Yeah, I
Yes,
think.
exactly. And you told him no, it
Yes, yes,
started
yes,
only
yes,
last
yes,
week.
yes,
So the best
Yes,
yes.
thing is previous attack.
previous attack. Yeah,
Yes.
they count this word previous attack. Okay, and what else? I think that's it. For the history, for the examination, you did all. Maybe the cranial nerves. You can just maybe examine one cranial nerve for completion, and the gate in the end you did it, and the back maybe you just have a quick look to the back. In the management and the plan, okay, all fine. Nothing from my side. Thank you so much.
Yeah, thank you, Dr. Ryan. Very nice case and presentation and performance, either as surrogate or candidate. I want to ask Dr. Azhar one more question. What the mode of inheritance in thyrotoxic periodic paralysis?
Autonomic dominant.
Yeah, autonomic?
Dominant.
Yeah, but autosomal, not autonomic.
Autosomal.
Sorry, autosomal dominant.
You're, you're,
Autosomal.
you're sleepy.
Autosomal dominant. Autosomal
You want
dominant.
to
Yes.
sleep? Yes.
Yes.
Okay. Okay. Yeah, let's start comment as Dr. Ryan.
Excuse me, 1 minute. You
Yeah,
were
sure.
asking me and Dr. Ryan, what is the mnemonic I have made? Phase. F mean fasting.
Mhm.
C mean
Fasting. Okay.
carbohydrate. Fasting,
Mm.
because fasting will be hyperkalemic paralysis.
Mm.
And C for
Okay.
high carbohydrate, right? E for exercise. because sometimes the patient is presenting with the fasting, sometimes
McCardle?
with the
Mm.
high carbohydrate, sometimes he present with heavy exercise, and then the secondary cause you can ask for the thyroid problem. Face you, if you will memorize this, then you can ask all the question. Fasting, carbohydrate, FA, fasting, C mean carbohydrate, E mean exercise. I will write in the
Mm.
chat box.
Thank you.
Yeah, too much
Well,
appreciated. Okay, let's start the comments, the onset, course, duration, the analysis of the complaint, the sides, and the previous attack is very important. And the nature, yeah, someone wrote it. Yes, it's one of the important question. What the nature of this weakness? Is it floppy or stiffy one?
uh, very
And I
good.
think
This is
Yeah,
he did not ask me also where is the
yeah,
weakness.
he-
Like is it in the
exactly.
how
Yeah,
is it progressing?
yeah, in the
Is it
proximal or distal, yes. And also the nature is very important. It will give you a clue about either upper motor neuron or lower motor neuron.
very good,
Mm.
very good.
Yeah,
Yes, I follow floppy,
yeah, yeah.
floppy.
Floppy one or stiffy one. Okay, if it's stiffy one, what do you suspect?
I can suspect subacute combined degeneration,
Okay,
and then I
okay,
will go for the numbness and tingling sensation. I will go for the dietary history.
okay. And what important in female, in young female, very important presentation. Disease.
For the periods,
Yes, multiple sclerosis. Yeah, multiple sclerosis.
MS.
very good, multiple sclerosis.
Yeah, so stiffy in young female, on and off, multiple sclerosis in the top. Otherwise, yes, you can say subacute combined degeneration, or you can suspect dorsal column or any disc lesion or something in the spinal cord as upper motor neuron lesion. Okay, and you have to ask about trauma, which you did in this scenario, and it was great to ask about trauma. Again, whenever we have, let's make it as a habit. Whenever you have complaint, you have to think about the severe form of the complaint. As Dr. Ryan said, you have weakness, you have to rule out the alarming signs of the weakness, which are any loss of control over the waterwork or back passage, and the sensation affection as well, or trauma. All this will give you alarm. You have to have neurosurgical immediate or urgent intervention. The patient might have cord compression, and it might be for the welfare. You have to inform the neurosurgery for intervention, possible intervention. Okay, along with back pain, of course. If he has or she has back pain, you can suspect uh, spinal cord lesion or something serious in the spinal cord. Okay, back to the analysis. As you start to suspect something related to food intake, so you make your differential narrow, and you suspect either periodic hypokalemic or hyperkalemic or thyrotoxic. One, and you started to analyze more which system related. The CNS, you ask for the CNS quick review, any sensation affection, any blurring of vision affection, and you can ask also about the balance, and you can specify the diet for if you suspect, I mean, any vegetarian patient, he might have subacute combined degeneration, but it will be the opposite. The patient will be in the stiffy weakness. Let's go back to the thyroid. You suspect the patient is having thyroid from the question of bowel habit. It was very uh, pathognomonic for hyperthyroid state. How? Patient has loose motion, anxious, shakiness, sweaty in the hand, palpitation, and she told you I have lump in front of my neck. If you ask about the weight, patient will lose weight, although she has good appetite. All this will go with hyperthyroid or thyrotoxicosis. You can ask about the face or the eyelids if you want. You can ask as well for family history. Once she said to you, I don't live with my family, I am adopted, or it will be like positive family history in the form of father or mother, I mean parents, so autosomal dominant condition. You can also confirm the diagnosis from the family history. I think this is for the history. You cover the whole, including the thyroid finding and so on. Okay. Let's go to the examination. What parts you have to examine in this patient particularly? You have 3 parts to examine, right? In any thyroid scenario, you have 3 parts. Starting from the periphery, I mean the hands, you can find a lot of findings. Then the most important, the thyroid gland. The next in the importance are the eyes. And in this scenario, you will finish examination or you endure the examination by examining the legs. Because
Heart
this
also.
is, sorry?
And heart also.
Heart, yes, it's quick examination, but it's not in details like the thyroid and the eyes. Because most of the finding, it will be in these organs. I mean the eye and the thyroid. The weakness, of course, you have to examine full neurological examination. The heart, you can, yes, just quick examine the heart, any murmur, because what you suspect else in the heart failure. But you have to do, yes, you're right, you have to pass through, but don't miss the legs. If you will do examination of one of them, the legs will be more prior than the heart, because this is the complaint. But if you have time, you can go back to the heart, you can do cranial nerve examination, but you have to examine from the hand related to the heart what? The pulse, irregularity or regularity, and the pulse volume. In the thyrotoxicosis will be high pulse volume, and it might be associated with AFib. So you can get the clue even from the hand. Okay, back to the hand. The sweating, you will consider in the front, in the palm, I mean, and in the back, you can do the tremors, fine tremors, and acrobacy in the joints, distal joints, and the pulse, as I mentioned, the pulse, it will be a high volume pulse with irregularity if the patient is having AFib. This is the hand examination and finding. Proximal myopathy is very important as well for hyperthyroid. You can consider examining the proximal myopathy and go direct to the eye for either exophthalmos or proptosis and lid lag. And don't forget the diplopia or the H shape for any diplopia. You can quick offer the fundoscopy and pupil examination, reflexes, I mean. Again, we'll go to the or proptosis. You know how to examine the proptosis and exophthalmos and the lid lag, or need to mention? I think most of us knows how to do it.
Yeah.
Okay, so let's go to the thyroid. The next step, the thyroid, as you did. First inspection. You have to stand in front, offer him water, sip of water to drink. Can you drink, please? Yes, and you will notice the movement with the swallowing. As you did, please, can you protrude your tongue out just to confirm this is not related to the tongue and it's something in the thyroid, I mean. Okay, then we finish the inspection. Any scar, you have also to know or to find any scar. And of course, the size of the gland, is it diffuse? Then you will stand behind and you have to inform the patient, I will stand behind you to examine the gland. Then you palpate from area, from side and push from other side. This is the thyroid examination, how to examine. And again, offer him sip of water. Can you drink, please, for me? This is for palpation. And percussion, you have to do retrosternal percussion. I guess you didn't do, Dr. Azhar. And auscultation, you auscultate for Berwi, you did it. Okay. The lymph node here is important, as Dr. Azhar did. And I guess this is a full thyroid examination. Then we will go, as Dr. Azhar said, the heart, quick examination, any murmur, S1, S2, and be sure there is no S4 or S3, I mean as heart failure sign, along with raised GVP. And always do raised GVP while patient sitting. And end your examination by doing the leg examination first by inspection, any edema for the thyrotoxic state, and the tone, power, reflex, coordination, sensation. Any affection to the peripheral nerve, you have to do all steps. Don't do one step. So patient came with weakness. Don't say I will examine the power only. You have to examine all the steps. Started in the same order. Tone, power, reflex, coordination, sensation. Because once you start with any of them out of the order, you will forget the others. And they will comment on you on this. So please start in order. Tone, power, reflex, sensation, coordination, sensation. One by one till the end. Then end your examination in the neurological examination by doing the gait. In this patient, he might say, I can't walk, I have weakness, or he will walk with walking aid, or he will walk with raising his legs because of floppy weakness or flaccid weakness. This is the finding in the all station and in the all patient examination. Anyone has comment or adding point?
Yes, Dr. Basu, I want to add something
Yeah,
which I
sure.
forget. During hypokalemic attacks,
Mm-hmm.
CK enzymes also rises during the attacks. So CK enzyme should be mentioned. And ECG is very important. It will show bradycardia.
ECG and the attack of hypokalemia. Yes, yeah. Yes,
Yes,
you have
during
to mention ECG as hypokalemia finding in the ECG. So what I will ask you this question now. What the finding of ECG in hypokalemia or hypokalemia finding?
there may be bradycardia, flattening of the T waves. There may be more specific U waves and
Excellent.
ST segment depression maybe.
Yeah, so the most important, the U wave. It's pathognomonic and you have to mention it.
Yes.
Okay. So this is
And
the,
one more,
yes, what else? Yeah, go ahead.
one more the treatment, I forget. In acute attack, we will give the potassium orally, not the IV.
Mm-hmm.
IV we will give in cardiac arrhythmia. If there is a
Yes,
cardiac
exactly.
arrhythmia, then we will give IV. But if there is
Yes,
no cardiac arrhythmia, we will give oral potassium.
yes, you're right. Whenever
And
you have symptomatic hypokalemia, you have to give IV potassium correction. Yes. What else? Yes.
and and if the patient is having recurrent attacks, then you can give dichlorphenamide, 50 to 100 milligram BID. Dichlorphenamide for
You can
to
consider
prevent.
also aldactone, potassium sparing antidiuretics.
Yes,
Potassium sparing diuretics. Yes.
yes.
Again, mention your drug. The one you mentioned.
Dichlorphenamide,
Mm-hmm.
50 to 100 milligram BID.
Mm-hmm.
And one question I want to ask from Dr.
Yes.
Rayan. Uh, so I took pasta with my friends. I only developed this problem. Why not all my friends? They are all are healthy. What is the reason?
It's an enzyme defect. What should it's only in the patient.
Why? Why only in me? Why not my friends?
Mm,
You ask this
Because
question as concern, you
because
mean?
because it's the autosomal dominant. And
yeah,
maybe these my friends they don't have this autosomal dominant problem.
for
So
sure
why
they
I'm
don't.
having? That's why you did not give me the history that I'm adopted. I do not know about my family. I'm
No, she
living
said.
separately.
I
So it's
told you that
okay.
I am not living with my family.
Yeah, she
Yeah.
said, Dr. Azhar. She said, I don't live with my family.
So examiner may ask, why not my friend they develop this problem? Why? Because I'm having autosomal dominant problem.
Dominant.
They may not be having this problem.
Yeah.
Why me, you mean? Why me having this problem, not them, and not others?
Yes,
Yeah.
yes,
Yes.
Yeah, it's familial condition. So this is the
it's a
answer also.
familiar,
You have
familiar condition.
familial condition, yes. Okay. Any more comment, Dr. Azhar?
No.
Any question, Dr. Ryan, Dr. Azhar? Really very nice
Thank you.
session and informative cases. I like the performance for both of you. I enjoyed the whole session, really.
Thank you, thank you.
Thank you so
Thank
much.
you also, Dr. Azhar, Dr. Ryan. Any question from others, please feel free to ask. Okay. With thyrotoxic periodic paralysis, is it hypocalcemic? No, it's hypokalemic. Yeah, hypokalemic. Yes, hypokalemic.
Yes, both hypokalemic.
Yes, this is different from the hypokalemic itself.
I will send the table in the
definition.
group.
Yeah,
Yes,
the
very nice
definition.
table. Yes.
Okay, please, yes.
Okay.
And by the way, all of them are autosomal dominant.
Yes, all are autosomal dominant.
Yes, exactly. Yeah, Dr. Ritaj ask you where the mnemonic, Dr. Azhar. Write it, please. Okay, he will write it in the group as usual. He's writing after the session.
Okay, I will write. I will write.
Okay. I have comment Dr. Samah saying used multiple jargon. No, I don't think he mentioned any jargon, Dr. Samah. Anyway, you can write and give us some examples what he said. Yes, one important question I forget. I'm always writing in the chat box to remind myself because sometimes I am not remembering while commenting. The infection in this scenario very important. What do you think, Dr. Azhar, the infection clue in patient with weakness in the lower limb? What do you think the possible cause? If the patient having recent infection, especially GI, for example.
Guillain-Barré syndrome.
Excellent. Yes. You have to ask any, it might be the case, and you will roam around asking here and there, but you will not find anything. And one question can give you the clue, which is any history of infection.
Especially I said diarrhea. So
Yeah, she said diarrhea. I suspect really, I thought there is relation between the diarrhea and this weakness. And I can put as well the Guillain-Barré one of the differential. Because
but the hyperreflexia is going against Guillain-Barré.
yes,
The hyperreflexia in the examination.
yeah.
But the
So
history in Guillain-Barré, it will be
of
round about
course,
2 weeks, not one day.
exactly, and it will be ascending viruses. It will be also a follow with infection.
Yes, yes. But history
Yeah,
very important, 2 weeks. And
But
then
maybe
exactly.
this diarrhea is infection. Maybe the diarrhea is infection that we don't know. So
Yes,
it's
you have
important
to
differential, as
analyze.
you said.
Yeah.
Yes.
So yes, you
yes,
have to
very good, very
analyze it.
good. Because you have given the history of diarrhea from last 1 month. So it can
Yes.
be put at the end. At the
Yes,
end, it can be put.
exactly. Yes, yes,
Very
exactly.
good, very good. It can be put. Very good.
Yeah, and the difference here will be reflexia, as Dr. Ryan said. Here,
Yes.
exaggerated reflex because of the thyrotoxicose. Yes. Okay. Thank you for this comments. Any other rituximab in failure of steroid for eye disease? Yes, rituximab is considered for the eye manifestation post steroid if the steroid failed. Stop smoking, yes, of course, is very important advice. If you have patient with the exophthalmos or any eye disease, you have to ask him to stop smoking. Pressure symptoms. Yeah, I mentioned compression symptoms. Yes, it's pressure symptoms or compression. Yeah, but any meaning with this. So any compression or pressure symptoms, you have to consider the surgical intervention. And the management always multidisciplinary team as we used to do. Any patient with multi-system affection, we have to call for multidisciplinary team approach.
Now,
Okay,
now
nice. Yes.
this rituximab now we are using in many diseases
Yes,
like
let's mention them.
pemphigus vulgaris. Pemphigus vulgaris. Before the first line treatment was steroid. Now
Yes,
the first line treatment is rituximab,
excellent. Okay, what else?
and then systemic sclerosis. If you will give a steroid sparing agent, you definitely have to mention rituximab also.
Okay, what else? One more important disease.
There are 2, 3.
Yeah,
You
one
give.
more.
Yeah, yes. There are 3, 4 in diseases. I not
Okay,
remembering.
GPA. GPA, granulomatosis with polyangiitis. Rituximab,
Okay.
one of the management after
Yes,
plasmapheresis.
yes, 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 yes. And if you I have noticed in vasculitis, if the examiner again and asking you, give me one more example in vasculitis, what the steroid sparing jet, always say
Biological.
cyclophosphamide.
Uh-huh.
Cyclophosphamide. If you will read in the books around about in every scenario, they will say cyclophosphamide in
Mhm.
vasculitis.
Especially also the GPA.
Yes, 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 yes.
Yeah. And if also in advanced management failure with multiple medication, I guess monoclonal or biological therapy has role for some disease, like for example, rheumatoid arthritis. TNF and biological therapy are now they are trending now for the management of rheumatoid arthritis, like adalimumab and etanercept, infliximab. Yeah, so we can make a revision for this biological therapy in basis one day.
Inshallah, one day we will have.
Yes, okay, thank you. Botulinum, yeah, I agree for botulinum, but it will be also
This
generalized, not
descending.
I
descending,
think
exactly.
descending, yes.
Yeah, and it will affect the face
The face and the
and
bulba.
exactly before reaching the legs. But for ascending, starting by legs, you can suspect Guillain-Barré further.
Diplopia, facial muscle weakness in
Mhm.
botulism.
Yeah, and also with mydriasis.
Matrices, very good. Yes, yes, matrices.
Yes, I said the potassium 1 millimole per kg. No, it's not 1 millimole. Up to 120 millimole per day. You can give potassium, not 1 millimole per kg, because you are giving 10 millimole per hour. So you can reach up to 100 millimole per day. This is the highest dose. In severe hypokalemia, I mean. Okay. Okay, history of injection, history of vaccination, if you want to suspect vaccination, not injection. Any other comment, any question? Inflammatory bowel disease, yes, yeah, they are using also monoclonal. Any comment, any question from anyone? Please share it. We have very nice interactive session today, really, with Dr. Azhan and Dr. Ryan, and all of you. The session is nice by your attendance, and always amazing by the interaction in between. Thank you all. If no more question, we can end the session. We'll see you tomorrow, inshallah, with communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.